Hi, I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
And this is
A Pod Full of Pediatrics.
Subscribe here for more content.
Or go to onecommunityhealth.org.
Or follow us at One Community Gorge. And this is the one where we talk about urinary issues from birth to toilet training and beyond. So we're going to talk about urinary tract issues from a pediatric perspective, which actually starts before the babies are even born.
That's right. When they are inside their mom's belly, it is when you're looking at the urinary tract through those first ultrasounds and kind of seeing if everything's healthy. The urinary tract is comprised of your kidneys, ureters. Bladder and urethra.
And the urethra is a skinny little tube you pee through, which is obviously a different length depending on if you have a penis or not.
That's right. When we talk about those in utero diagnoses, one of the biggest things they often find on ultrasound is something called hydronephrosis.
And this is when things are swollen inside the urinary tract. And the ultrasound person grades it from 0 to 4 when they're measuring the amount of swelling on a kidney.
And it's usually diagnosed in about 5% of pregnancies. It usually means that there's a narrowing or like something that gets smaller in the urinary tract system at some point, and basically things back up. So that swelling is fluid that's kind of backing up behind that narrowed part.
So after the baby is born, it's really important you tell your baby's pediatrician about this ultrasound finding because sometimes we just don't know.
Yeah, lots of times actually we don't get those records from your pregnancy. All we get are the delivery records, and if it doesn't have those in there, we have no idea of what might have been found.
We cannot see inside.
So if at some point somebody said, "Hey, your baby has hydronephrosis and this is going to need to get followed," definitely tell your provider after the baby's born and you go to those first newborn visits.
Because we want to repeat the ultrasound after the baby's born, because sometimes that pressure is just literally from being squished inside the mom. When you get out and you're like, hey, there's enough space. That's good. It resolves.
And it just goes away. If it doesn't go away, though, and it persists, then we do need to follow the progress. And even after the baby's born, it'll sometimes resolve. But if it's not resolving or the swelling's significant, then your baby is going to be referred to a pediatric urologist, meaning the urinary system specialist.
Exactly. Vesicular-ureteral reflux, what we call VUR, accounts for about 10% of those cases of neonatal hydronephrosis.
And vesicular-ureteral reflux is really hard to say.
Exactly.
But basically, it means that things are going back instead of down.
So things are going north instead of south, and that is not how the system is supposed to work.
And unfortunately, what ends up happening is that it can be a major cause of urinary tract infections, and definitely higher rates of urinary tract infections in those children who have vesicular-ureteral reflux. Basically, because that fluid is kind of going up instead of back, and because it kind of stays there longer than it should, little types like the urinary tract, the system in urine is actually pretty sterile in general, but sometimes little bugs get in and they're supposed to just stay in the bladder, and if they don't and they go all the way up into the kidneys, you can have real problems.
So again, if your child is diagnosed with VUR, they'll be followed by a pediatric urologist, and they may be on daily antibiotics until the condition resolves.
And that's really to prevent those infections from happening.
Also in utero, there can be other conditions that are diagnosed, such as like having one kidney, a horseshoe kidney. Again, tell your provider because we do not know these things.
That's right. And it is really important that those get followed, and they will typically get followed by a pediatric urologist.
So circumcision. This is a super interesting topic because perspectives have changed on its relevancy over the years.
Yeah. So when we first came out in practice, actually, really, I would say a significant portion of people had their infants circumcised. And actually, it was typically covered by insurance. Like in general, almost all over the country, it was covered by insurance. And that was because originally there was some evidence that circumcising your boy infant actually led to a decrease in urinary tract infections. Over the last 35 years, we have really emphasized what we call evidence-based medicine. And that's all that we have tried to present to you guys in all of these podcasts.
And the difference has been that now we can share knowledge, right? It used to be that you could only get research from a journal. You have to look up this certain paper. now with the internet, despite its disadvantages, it has some real advantages of communication between different scientific organizations.
Yeah, when we were in medical school and residency, you literally had to go to the library, ask for the journal,
and even to know about there was a journal, right?
Right.
Yeah.
And so information got disseminated a little more slowly. Now information, really good, accurate, researched information, and huge meta-analyses of information where we can really look at what the findings are in all of these different studies and kind of like have a cumulative knowledge based on all these different studies. And that's what they used to look at circumcision and say, guess what? It actually is not that big, the change in the risk of urinary tract infection in male infants, whether circumcised or uncircumcised. And so now circumcision is really more about like religious or cultural choices, or
Kind of
just
a
familial
personal choice for your
personal
kid.
choice. Yeah.
And as you probably know, this procedure refers to surgical removal of the prepuce, that's a weird word, the foreskin of the penis. And U.S. is the only resource-abundant country where the majority of male infants are still circumcised for non-religious reasons.
Right. So if you look at a review of hospitalization data in 2012, about 54% of male infants were circumcised, and in 2022, about 49%.
So it's
So
gone
a little bit less
down
than
a
the
little
majority.
bit. But there's such a difference. You know, I moved here a year ago from Indiana. In Indiana, the majority of boys were circumcised. The rate in Midwestern states about 74%. And then Northeastern is like 67%, South 60%, and then in the West 30%. So it's a big change for me to come from where most boys were circumcised to now being less the majority of circumcised.
And we talked about the religious affiliation. Sometimes it is actually a standard procedure in some religions. In other cases, it really depends slightly on ethnicity too. Like if you look at, like we said, non-Hispanic Black Americans, about 60% are circumcised. Non-Hispanic White Americans, about 40%. Native Americans, about 37%. And only about 21% of Hispanic Americans.
Yeah. And outside the U.S., it's a really big range too. From like some countries less than 5%, like I grew up in England, that is definitely less than 5%. Pretty much only people who are Jewish have circumcisions there. To other countries where it might be greater than 90%, such in some African countries.
But again, one of the major reasons that it was covered before and not now is because they thought that there was this association with urinary tract infection. And when we look at the meta-analysis, meaning a big review of all of these studies, it's actually not that much increase. So it goes from about 1 to 2 in 1,000 for circumcised males for urinary tract infection to about 7 to 14 per 1,000 in uncircumcised males. And in general, that's not enough to recommend circumcision on a regular
Never
basis.
recommend the urinary tract infections.
No, never recommend that. But don't recommend. That's why they don't necessarily recommend, and they don't pay for in most states.
As I say, and interesting because in Indiana it is covered because circumcisions are done in the hospital and they're part of the bundle of the birth of the child bill, right? They're not necessarily separated out from most insurances.
Right. Whereas here we do them mostly out of the hospital, and they don't cover that procedure by itself.
So the other reason to talk about doing circumcision is for hygiene. But again, this is something that you can do without getting a circumcision. You can teach your little boy how to do good hygiene and then not have concerns about it later.
And one of the big things about genital hygiene is that you just kind of wash with soap and water while bathing. It doesn't have to be a specific option. As they get as they get older, it is important to teach them how to do it though. And especially to make it a normal part of like care for their body. Hygiene is hygiene, right? No matter which part of your body you're taking into account.
And we've talked about this before, like the secret to parenting, right? Is you just keep doing it. And then eventually they're like, oh, this is how life is. So kind of, age 3, you just really work on in the bath. This is how we wash our penis.
That's right. And for uncircumcised boys, it is a little different. Circumcised, like hygiene, pretty easy. You just wash with soap and water. Uncircumcised hygiene, there is a little bit more of nuance to it in the sense that the foreskin does need to be kind of retracted back a little bit. Eventually, the foreskin should retract back completely, like definitely prior to puberty, where the foreskin will kind of move backwards and forwards.
And usually around 4 to 6, it starts to come back naturally by itself. So at the beginning, don't force it back with the babies. Just slightly pull it back, wash off the end. And as they get to toddler age, let them do it because they won't do it enough to hurt, right? They'll pull it back gently and wash off, anything that kind of builds up underneath this foreskin.
And this is, again, one of those evidence-based things where when we were in medical school, we recommended, like, really parents retract the foreskin with every diaper change, like a little bit, right? And clean. And they found that some parents did that really well, and some parents were a little too aggressive.
Yes,
like,
get everything really clean.
It had to be really clean. And so caused some pain or discomfort for infants. And they're like, you don't really need to do that. Like, we can wait until they can do it themselves. But in our haste of not telling parents to retract, sometimes we don't emphasize enough, I feel like now, that there actually does need to be some gentle retraction that happens over time, or that foreskin can kind of get tight, adhesed to that area, whether it just be because now we're wearing diapers more,
things are wet in there.
Things are wet and kind of adhese more. But either way, it is part of that hygiene and recommendations for when they, especially when they start bathing and taking care of the penis themselves, to gently retract and wash with water.
I like how we say the penis, taking care of the penis. So there's something called smegma, which is such a weird word. I don't really like it. She kind of likes it.
I do. I think it's such a great descriptive
Oh, I think it just
term.
kind of sounds like snot. But it's when like dead skin kind of gets trapped underneath the foreskin, and it kind of squeezes out almost like a zit a little bit. And you don't have to hurry it along. You just, in the bath, wash out the stuff that's coming out naturally by itself.
That's right. It is not pus, and it is not infected. So it does not, you don't have to do anything else with it. Again, it's just that gentle wash with water with gentle retraction is all you have to do.
The other thing that can happen with uncircumcised penises is you can sometimes have ballooning as they're peeing. Things kind of swell up at the end. And a little bit, that's okay. But if it's enough where like they're having to shove it down so they can pee, you're like, oh, that's too tight at the end.
Again, pee is supposed to go out, not back.
Yes.
So if the hole is so tight that pee kind of starts going backwards in between the foreskin and the penile head, that is actually not normal. So and if that happens pretty frequently, they are going to recommend things to help with that, like to either thin that skin around the penis, or even occasionally, if it's really severe, they might recommend circumcision.
So balanitis is another thing that we see pretty commonly with uncircumcised penises, and that is like inflammation of the end of the penis. So there is like a big long fancy word for it, balanopostitis, for all of the inflamed part.
I've never
It
said
sounds
correctly.
like a Greek island, so we just don't use that word that much. We just say balanitis. And it's not subtle. We're not going to show you pictures, not like with our rash podcast where we show you pictures, because you can imagine what it would look like where the end of the penis was red, swollen, and really hurt a lot.
Yeah, and it does hurt for kids. It'll hurt to pee. It'll be quite uncomfortable for them. And there's lots of reasons, again, for this type of inflammation. But most commonly, there are two. One is that they're boys. They will like to touch themselves there. Mm-hmm. Okay, so this happens
when they pee. They have to touch the parts.
I know, but they touch for other reasons.
They touch for other reasons too. Yes,
so,
exactly.
Like, it's gonna happen.
Yeah,
it's really a normal part of being a little boy and girl, for that matter. But they're gonna touch there, and often they don't wash their hands before they touch. Mm-hmm. So all the bacteria and all that kind of stuff on their hands actually kind of gets on their penis, and sometimes that bacteria can kind of, especially if things are tight or irritated, they'll kind of get in the skin there, and you'll have a bacterial infection. The other thing that is really common is that it stays a little moist.
Yes, a little irritated and inflamed there. And then you get either a secondary fungus or you just get some inflammation.
Right. And so either of those things, you typically treat this with either topical antibiotic ointment, like for those bacteria on the hands, or like an antifungal if it's like for the yeast or like fungal ones coming from kind of moistness.
But again, it goes back to hygiene. have them sit in a warm bath and kind of ease out some of the irritation before you put the cream on there.
Yeah, and the other important part of that is it will hurt to pee while
Yes.
it's inflamed. And so often those like long baths or those types of things can help with like peeing in the bath, like is a lot less painful than peeing, like trying to pee in the toilet or that type of thing.
Because they can hold it really impressively
They
sometimes.
really can.
Yes.
And like I've seen kids hold it with balanitis for a really long time, and it's super stressful for parents, and baths can really be helpful.
There. So urinary tract infections, as we referenced before, can be a concern at any age, but they're most concerning during infancy.
Yeah, it can occur even if there's no underlying anatomical reason, like we talked about with the vesicular reflex. They can occur no matter what. But if they occur, anatomical reason. But typically, if kids have underlying immune deficiencies or that, they're much more likely to have
Or just
urinary tract
babies can't
infections.
fight things off very well.
That's right.
Which is why they need vaccines.
That's right.
Yes. So the urinary symptoms we associate with a urinary tract infection in an adult are not always relevant in a baby or kid. We can't tell they're having urinary frequency or pain or urgency because they're in diapers.
And they're drinking a lot, so they're peeing a lot. Like
Yes.
we, in fact, like expect them to pee a lot. So again, we won't know that those are differences. And so often for urinary tract infection in infants, it's just fever and fussiness.
It is. And so, if the baby has fever, we're going to check to make sure they don't have infection, which typically is going to be a catheter, a bladder catheter to check because, again, we can't really catch urine most of the time.
That's right. And so it is really important to recognize that if you are going to bring them in, they might need to do that urine, and it will be safe. It is a little bit uncomfortable, but they'll do fine afterwards. But they really do need to check a clean urine to make sure.
Yeah, and when we do the bag urines, which is like where they put a bag on the girl or the boy to catch the pee, they're just going to have an increased risk of contamination. So sometimes we do that if we're not really worried, but if they have a sick baby who has high fever, we need to know for sure.
That's right. Females have a 2 to 4 fold higher prevalence of UTI than do circumcised males, and the prevalence is highest among uncircumcised males, particularly those who are younger than 3 months, if you are male.
And the overall prevalence of a UTI is about 7% in infants with a fever.
The other thing we like to remind, and this is actually reminding us, truthfully, is that when we send off these urines, sometimes it's kind of this urine with reflex to culture, which is great for adults, not so great for kids, because the urinalysis sometimes doesn't look quite the same. Because
kids have little bladders, so they're constantly turning over. So the urinalysis might look clean.
That's right. But it will still grow out bacteria. And so we always need a urine culture. And that urine culture is not only really important to make sure that you have a urinary tract infection, but also what type of bacteria is causing the urinary tract infection so that we can best treat it. Because urinary tract infection, especially in infants, require IV antibiotics of a specific type to cover those.
So if you ever have a urine sent on your baby or child, make sure they send a urine culture. And you can just say that to the provider, did you send that for culture? And they'll be kind of annoyed, but it really is the best choice because the urinalysis is that day. The culture is going to take 2 to 3 days to get the answer, but it is the true answer of what's actually happening.
And it is really important because we treat urinary tract infections not only to, prevent further pain and worsening of the infection into a systemic infection, but also because any of those infections can actually cause kidney scarring.
Yes, and kidney scarring sounds like exactly what it is, right? It makes the kidney not work as well. It can make you end up with high blood pressure and actually renal failure as adults.
Mm-hmm. So predictors of kidney scarring after a first UTI were investigated they did, again, a meta-analysis, means a bunch of different studies, but about 1,200 children from 0 to 18 years, and they noticed scarring at least 5 months after their first UTI.
And it was about 15% of kids.
Yeah, so children with an abnormal kidney ultrasound finding or with a combination of high fever and bacteria other than E. coli are at high risk for kidney scarring, about 30%.
So again, send the urine culture. That was the message.
Really important. So then we're going to talk about toilet training. And I kind of we get asked about this so much.
It is kind of a daily question because it is hard.
It is. It is training.
It is training for everyone, and we talk about there's 2 different kind of methods. One is like a parent-centered and one is a child-centered. And they're both okay. When they look at them, they're like, They both work. They're both fine.
I don't know if there's ever been a head-to-head analysis though of which one.
No, but at the end of the day,
They're-
kids are not scarred by
kids get
it,
potty
and they're potty
trained.
trained, right?
Yeah. It does vary by time, culture, and like kind of the definition at the endpoint of toilet training. So do they have to be accident free, or are they just going to be able to go to the toilet on their own or when you ask them to?
So most kids achieve bowel control before or at the same time as daytime bladder control. But about 10% of kids get bladder control first.
And nighttime, we will distinguish between nighttime bladder control and daytime bladder control, because that actually is a big difference. And we're not going to talk a lot about the nighttime bladder control during this episode. We'll talk about it at the next one.
And the deal is, in daytime you're conscious, nighttime you're not. So you don't get a lot of choice over what's happening at night.
That's right.
So the average length of time required to achieve potty training is about 6 months for daytime urinary continence and 6 to 7 months for stool continence.
And some of it really depends on when you initiate and how, again, how much of that is child-led. If the child is really, they're talking, they can tell you when they have to go to the bathroom, they're at an age where they like having having a wet diaper, that type of thing is very uncomfortable for them, it's going to go faster. Right. Whereas if you start it really younger, before they can talk well or do that, you can still potty train. It's going to take a lot longer.
Yeah, and the stats are that female children complete toilet training earlier than do males, but that's a lot to do with females are typically more verbal than males. And first children take longer to potty train than subsequent siblings, and that's a lot to do with role models.
Yes. And again, we talked about kind of the parent controlled or the child oriented. And parent controlled is basically, and I didn't realize that in different cultures until you kind of talked about it, that's all parent controlled. Like sometimes they don't even do diapers. They just basically kind of.
Yes. In some Asian countries, they really just take the kids to the potty all the time, and then they have them wear kind of pants with a hole in the bottom, so when they're out in public, if they have an accident, they can't take them to potty, they just can pee through the hole in their pants.
Yeah, not as like most people in the United States are not as comfortable with that necessarily.
Yeah, and when I had patients from other countries, I'd have to remind them that in our office was not the okay place to pee, right? Outside, but not so much in here. Yes.
Right. And so the other one is that you wait until the child can tell you, or at least they can sense it. You know that they're sensing that they don't like being wet or when it's coming or that type of thing. And then you do potty training at that point. Sometimes that can be just the parent taking them every 2 hours, right? And it was really interesting because when you look at this, even in the United States, this has changed over the last 50 years.
Yeah.
Right?
Well, yeah, exactly right. When parents were home more, when moms were home more with the kids, potty training was done early because you could just take the kid to the potty all the time.
Right.
But now when both parents are working and there's other sitters involved.
Sometimes daycare involved, preschool, babysitters or nannies, as well as parents. Like that's a lot of people trying to remember when that child last went to the bathroom. so it's not as easy. So we kind of
the American Academy of Pediatrics recommended the child oriented approach, and that is because we're child focused, but it's also just realistic to a lot of how people live these days.
That's right. And I have to say, like, if you're waiting for those things, then, there's even different methods within that. There's lots of books on potty training. Some of them we referenced in our references, but you can look through your own too. All of them have some degree of both parent kind of encouraging them to go, but the basic things that I talk about when you're doing when you're doing like child-led is, one, make sure you have a potty that's easy for them to use.
Yes.
If a child can't get up and get on the potty, like can't stay on the potty, doesn't feel
falls in the hole,
like falling.
They're going to get really scared about it and not enjoy it.
They're going to get scared and not enjoy it. So make sure you have a potty, like either a little potty or some like the contraption on top of the toilet that makes it much more comfortable and easy for them to do on their own. Because if they can't like pull down their pants and sit on the potty and do all that, it makes potty training much harder. And then, I talk about the fact that like my eldest child, I swear he would have like not potty trained forever. Like we had my daughter, and he was like, he's every day I'd ask him, "Hey, you want to try going to pee on the potty?" And he's like, "Maybe tomorrow, mommy."
And that's kind of the answer for everything.
Yeah, it was his answer for a lot of things, but it was like I was like scared he might be in college before he went to pee, right? Like on his own. I was like, we've got to do that. Plus, we needed to start preschool, and our preschool at that time said you cannot bring your child unless he's potty trained, and so it became all of a sudden a big thing where we had to get it done. Mm-hmm. And so we did like the how to potty train in 1 day method, and it worked great. It is a significant amount of bribery, which worked wonderful for him. Like he was like definitely bribable, and it worked great. And we were like he was daytime potty trained and within a day, and poop trained within a week, and he got to go to preschool, right?
Right. But it's different for different kids, right?
It is.
You have to find out what is going to motivate your child, because not everybody's motivated by the same tangible items. And also, you have to variable the incentives, right? If it's the same reward all the time, they get super bored by that. And, I remember my son saying one day, he's like, wait, this is what I have to do every day? Because, for a day it was kind of fun. And then he was like, wait, again today I have to do this? So you got to mix it up and make it interesting and make it fun, right? It's not punishment. It is like an exciting thing we're getting to do together. The kids are winning, That's how you make things more positive.
And we talked about this with the whole, constipation and getting them to go to the bathroom. If you make peeing and pooping fun and enjoyable and exciting, then your child will want to do it.
Yes.
If you make it kind of a time of where you get upset with them or
shame
them
when they have accidents.
Especially around accidents, it is not going to be fun. And then they are going to be really uncomfortable kind of talking to you about it and making sure like they'll do those things. And so rewards and fun, making things fun is actually one of the best parts. And patience. Yeah, have a lot of patience with it. And like I said, depending on your time will also depend on exactly when you want to start these things for your child. But we are watching for those times of developmental and behavioral readiness is going to be the most important part of when to start potty training your child.
We're going to talk about common urinary problems in kids after they finish the potty training.
That's right. And the most common problems after potty training really fall under the category of what we call voiding dysfunction,
which is super common, and it is about 40% of pediatric urologist clinic visits.
Let's talk about the term voiding because it kind of sounds really funny. And it's not a void like in a sci-fi.
No.
Voiding is just another term for urination or what we like to call peeing.
Yeah, and we're going to mostly just say peeing and pooping because we're pediatricians and we can.
That's right. We talk a lot about peeing and pooping.
Voiding sounds so grown up, but we don't
That's
like
right.
that. So in most kids, voiding dysfunction, peeing dysfunction, is a component of bowel and bladder dysfunction, right? Which describes abnormalities in both the bladder and the bowel at the same time. Again, more fancy words to say that peeing and pooping are very connected.
That's right. And again, we kind of want to remember that how our whole anatomy is and the fact that our urinary system, our kidneys kind of start off on the side, but they come together in the middle, like they kind of pour into the bladder, which is that big kind of bag. And then the urethra comes down out of that bag. And our stooling system, like all of our intestines, kind of come down to the same place, just behind that urinary tract. So if you have a lot of poop in there, it's going to press against the bladder and urethra, which then kind of can affect what children are feeling in those places.
And what are they able to do? Because all the muscles and the nerves are all shared there too. And so if they get kind of weak or confused, then you're going to kind of have mistakes in both the front and the back.
Right. And so earlier we talked about baby urinary issues and we talked a lot about the kidneys. And older kids, we're often going to talk a lot about the bladder. So that pretty simple bag that holds pee and then the trap door called the detrusor muscle that opens it. And that trap door is really affected or kind of controlled by nerves that are coming from like other areas in your body.
And yes, pretty simple construction, like open, close, but there's all these complex nerve and muscle interactions that can go wrong and then lead to different mixed messages.
That's right. So when defining urinary issues in kids, we need to talk about really expectations and bladder capacity, or that how big that bag is, is really based on age and size.
And so there's a math equation. I like these. The expected bladder capacity in milliliters is the age of the patient plus 2 times 30 milliliters, which 30 milliliters is an ounce. So that means that in babies, it's just 1 ounce. That's all right that they have in their bladder.
So in tiny infants, it's an ounce. Like by the time you're 12 to 24 months, it's only about 2 ounces. And then by the time you're 3 years old, it's closer to 4 ounces. And then and then when they're like in the adult range, it's actually closer to like more 10 to 15 ounces. So a big difference in how big that bladder is as you age.
Right. So keep this in mind when you're out somewhere with your newly potty trained 3-year-old and they can only hold it for like a little bit after they drank a drink in the Starbucks and you're in the grocery store and they're like, I have to pee now. They really do, because it's only holds 4 ounces and they just drank 4 ounces. That's right.
And it also is really important, like when you're on car trips, to recognize you're going to have to stop every couple hours.
Yes.
Like if your kid is drinking in his seat, that is going to need to come out. Yes. So we just like on trips planned, like every 2 hours, we're going to try to hit a gas station or some food type of thing.
Take breaks anyway.
It is. Yes. Get them out, get them walking, and make sure they pee. Even if they tell you they don't have to, that bladder is tiny.
Mm-hmm. So the issues we most see in bigger kids are incontinence, urinary frequency, and pain with urination.
And we're really going to talk here right now about daytime incontinence. We'll talk a little bit about the nighttime incontinence later. But when we talk about the daytime incontinence, it means that their ability not to control when they pee. And we separate that into really daytime wetting, which the causes are typically overactive bladder, voiding postponement, which is exactly what you think about. They're holding it too long, mm-hmm. or underactive bladder, and then dysfunctional voiding.
So overactive bladder, that's the kid that has a lot of urgency. You know, when your kid's like, I don't have to go. Oh my God, I have to go now, right? And those are the kids that seem like they need to go all the time, but then also doing this weird, we call it the Vincent's curtsy, where they like kind of squat and they cross their legs like they're like bending over because they're like
trying to hold it
in. I don't want to go right now.
The prevalence of overactive bladder in childhood decreases as kids get older, but it can cause a lot of daily stress. Like if you have a child that like won't go and then all of a sudden like has to go like immediately, and you are trying to go to go places or that type of thing, it can be super stressful for both the child and the family.
The next most likely cause is voiding, postponement, and underactive bladder, which, is when they're doing something like playing outside, watching a screen or whatever, and they just keep putting it off.
Right. And these are the kids that literally, you'll ask if they have to go to the bathroom and they're like doing a little potty dance and
yes.
like, no, I don't have to go.
And you're like, clearly you have to go. And they usually do not, as opposed to the overactive bladder that go all the time, these kids do not go a long time. And they can really go on a car trip a long time without peeing because their bladders get stretched out. And, parents are like, oh, they have camel bladders. That is not good. It is not healthy.
It's not a good thing, no. And some children with voiding postponement develop really that underactive bladder, the lazy bladder, where right. It just has been stretched so much that they actually sometimes don't even have normal, they either have poor or absent bladder contraction.
Yes, and so when they try to go, they have to kind of like push like they're trying to poop just to get the pee out, because everything has just become lazy and can't squeeze very well.
And often if that continues for long periods of time, you'll actually have overflow of urine. So meaning that they'll try to hold so much that it'll just basically leak
out there. And often these kids are at risk for urinary tract infections because they don't fully empty every time. So there's kind of just pee sitting in the bladder getting infected by bacteria.
Again, if you're pushing and pushing, but you don't push out enough, then that, especially some will just kind of get retained.
Yeah. And then dysfunctional voiding is often a consequence of the previous two. There are neurogenic causes that, kids are born with, like spina bifida, but we're not really going to talk about those. We're going to talk about the non-neurogenic, which often comes from overactive or underactive bladders.
And basically, when the detrusor muscle is squeezing during peeing, but the external urethral sphincter just stays closed. So basically, the muscle's trying to open, but the sphincter's just kind of staying closed.
The trap door is closed. Somebody put a little block of wood out in front of it, and they're like, I can't open the door.
And so it is dysfunctional voiding in children without a known or neurologic is characterized basically just that abnormal contraction of the pelvic floor musculature during voiding. And often their pee is kind of funny because it doesn't come out all at once. It'll come out like in
little spurts, little staccato. I like that word.
Yeah, I do too.
And it takes them forever to empty because they're just kind of spurting it out.
And one of the most important things here is, again, to emphasize that patients with dysfunctional voiding often have associated constipation or bowel dysfunction too.
Right. And if it's constipation is severe, they're going to start having poop accidents as well as having pee accidents.
And anytime you send these kids to the urologist, the pediatric urologist, the first thing they're going to ask is, how are they pooping? So it's funny, you're going to be all excited about telling them about your kids' pee, and instead they're going to ask how they're pooping.
Yes. And as we talked about in our constipation podcast, kids can poop every day and still be constipated, right? That is totally normal because they always do the minimum necessary, or they're doing really hard poops. So even when the kids get to the point where you're not going to the bathroom with them anymore, still figure out, is their poop big, small, hard, soft, what's going on?
And again, we talked about this before, it's okay to go and look at your kids poop afterwards. Yes, they're learning how to do all of this by themselves. They're learning all this hygiene. It's still okay and truly, how many kids flush every single time?
Very few.
So if you go in and there are these tiny little balls or these huge logs,
or you have to go in because they can't flush it.
That's right.
That means their constipation.
And treat that, and then focus on, at the same time, treating the things that help with voiding.
Yes. And kids with this dysfunctional voiding are really increased risk for urinary tract infection, like we said, and really increased for that vesicoureteral reflux we talked about earlier. And they may end up with renal problems, kidney problems their whole life, unless you kind of address it as a kid.
So again, things not coming out, going back, always bad.
Always bad. Go south, not north.
Then we talk about urinary frequency. And so this is a really common cause of urgent visits in our clinic. So urinary frequency just means that they're peeing more often than normal.
That person. So however that is defined for that person.
Okay, so sometimes it reflects that just they're drinking more water. They had a really big day. They're drinking a lot, and they're thirsty, and so they drink, and then they pee more, and that can be normal.
Or they're drinking caffeine.
They're drinking
energy
caffeine
drinks
for the first time. Energy drinks, those types of things, can cause you to pee more, or it can actually happen because of other things, like a urinary tract infection will cause you to pee more.
But the other part that I see a lot with the urinary frequency is urethral irritation. So that's the little tiny hole you pee out of just gets irritated, and it makes them feel like they need to go all the time.
Constipation, also another reason for increased urinary frequency. Again, one of the most common ones I see, because that poop in the rectum sitting right by the urethra, right? So it puts pressure on there, and then they actually don't have the same sensation. It makes sensation a little bit either. Or they sometimes feel like they just peed, but because it was kind of pushing on the bladder, they only peed out a little amount. And then now they have to pee again because they recognize the rest has to come out.
There. And then parents always worry about urinary frequency being diabetes, type 1 diabetes. It's obviously a symptom of that, that's the classic symptom, but it's not the only symptom. Kids who present with type 1 diabetes, they're sick. Mm-hmm. They have weight loss, they're really tired, and so urinary frequency is not the first symptom that's going to be noticed. So if your kid has urinary frequency, have them seen, but don't be all stressed out about it.
Right. We will get a urine. We'll check and make sure that there's not an infection, that there's not glucose that would signify diabetes. But don't worry about it, because that is by far not the most common cause of urinary frequency in children.
And the treatment course, has to match the cause, right? For those bladder dysfunction we talked about, we recommend going back to the basics.
Yes. So we really talk about setting a routine for peeing every 2 to 3 hours so kids don't have to depend on whether they feel like they need to go or not. Because again, sometimes those nerves and muscles aren't responding in the same way. So they might not get the same sensations they were getting before.
And I often recommend like a potty watch. Get them like a cute little digital watch and just set it for every 2 hours. And then they get excited about their watch. And that way they don't have to be dependent on like, am I full or not full with my bladder?
And I know that lots of times now, like you are not allowed to have watches in the schools, especially smartwatches and those types of things. But you can actually talk to your teacher. I've even written letters sometimes where the teacher will just remind the child to go every 2 hours. You know, interestingly, kids break a lot, and like teachers like are used to this, and so we'll kind of remind them to go to the bathroom.
Yeah. And when they do pee, have them go once and then count to 3 and try to go again so that they completely empty their bladder.
And then for little girls who quickly jump off and on the toilet, have them sit backwards so they can fully empty, which can prevent some of the urinary splashing. Like kind of sometimes like stuff comes back up and just keeps the vaginal area moist. And then it kind of leaks into the underwear and again keeps everything moist and irritated. But I will say like this is one of the biggest things for hygiene that I've had pediatric urologists talk to me about as well.
Yeah. Right. And that's the thing about hygiene. You know, at the beginning, you're going to help wipe, right? And then you're going to teach your little boy and girl how to wipe properly. And obviously for peeing with boys, we don't wipe. But with poop, this is the same conversation, right? Is you're kind of getting them to do front to back. But it's hard for a little kid to wipe.
Yeah, and it's really hard for little girls to wipe. Like most of our big person toilets are not ideal for little girls, right? Not ideal for little boys either, but definitely for little girls. Like for little girls, like you come and it, you know, like trying to like wipe front to back while you're like trying to balance on the toilet and you're scared you're gonna fall in, and sometimes the toilet
The automatic flusher's going
behind you. Like,
it's so stressful.
It's like so stressful, right? So what most little girls do is jump down, and then automatically when they bend over to wipe, everything's closed up. So the pee and wetness just kind of stays in between the labia, and everything gets irritated and red. You get extra rashes. It can have irritation.
And it's going to hurt to pee.
Yeah, it's going to hurt to pee. You're going to feel like you have to pee more. Like sometimes that little leakage, even after wetness has caused, either from splashing or just from not wiping well, leaks out and they think they peed, when actually they just kind of had leakage because it was never actually wiped well, right? All of those things can be thought of as urinary frequency, and what like that sitting backwards is so awesome, and it helps it. Everything's in the right position. They can hold on. They can wipe front to back. It is incredibly hard to get on the toilet. However,
I don't know. They're pretty motivated because it's silly. Like they think it's funny, right? We're sitting backwards on the toilet.
But you might have to help with that.
Have to help
and
them.
it's one of those things you do at home. You're not going to do that out, but it can really help practice good hygiene for wiping. And I think that's one of the really big important things for especially little girls for wiping and hygiene.
The other things that help urinary frequency is avoid the C's: carbonated drinks, caffeine, super citrusy drinks, chocolate, and food colors.
As well as constipation.
As well as constipation. That's the other C, for sure. Dysuria is the pain or burning to urination, which, you know, most of the time it's from the reasons we already discussed, like the irritation of the urethra or bladder dysfunction, leading to really concentrated urine or urine being trapped in the urethral vaginal area.
Again, UTIs can cause this sensation, but often there's other things like that come, other symptoms when they have a urinary tract infection. Increased frequency, tummy or back pain, fever, blood in the urine, any of those are more kind of characteristic for urinary tract infections. The most common cause of really dysuria is often, I feel like, all those things we discussed, especially hygiene.
Right. So again, if you come to the doctor with your child with urinary frequency or dysuria, we're going to check a urine sample to make sure it's not a UTI. If there's an infection, we're going to treat the short course of antibiotics. And until the antibiotics work, it's really important to drink a lot more water to flush out that bacteria from the bladder.
You can also drink some cranberry juice because that helps change the acidity of the urine, kind of to make it
the bacteria won't stay as
long. Yeah, the bacteria don't like that when it's really like when you change the acidity.
But drinking cranberry juice is really helpful in prevention more than actual treatment that much. And then we also talk about, taking baths to kind of calm down everything there. No bubbles, no soap, no shampoos. Like if you're going to wash their hair or body, just do it at the end so they're not sitting in the water.
And then air out parts when possible. Like it really is important. It is okay to let your child run around naked. Like it is
in your
okay.
house.
Yeah, in your house. Sorry,
not in public.
Like not in public so much, but totally in your house. It is absolutely okay. It helps air everything out.
I always say like have them wear a pretty princess dress. Just they can air out their bottom that way, and then they feel cool about it.
Do make them understand that they still have to wear underwear when they go outside. This was a big problem with my second child.
Yes.
Who really thought it was okay, like her not to wear underwear when she went outside. I was like, nope, it has to come on.
Yes. And if they're hot, sweaty, wet, like bathing suits, leotards, have them get out as quickly as they can after practice or after playing, because that just traps everything in and makes everything more irritated.
Yeah, really, especially here, I feel like in the summertime, like kids will run around in their bathing suit all day, and then and they'll do that for successive days in a row, right? And then parents will bring them in and they'll be like, but it's all red and irritated, and that is why.
You're like, of course.
Because it got wet, it dried very slowly, it got wet, it dried very slowly, right? It just stayed moist longer than it was supposed to.
Now we're going to talk about nocturnal enuresis, which means wetting at night.
Yeah. So really that nighttime wetting, that is very common and truly not always a medical problem.
There's a lot of genetics to when you actually achieve bladder control at night. Like you have to have two things going for you. You have to have the bladder capacity, and you have to be able to wake yourself out of sleep to go to the bathroom.
So it means that your brain has to be able to sense what the body's doing, and that those things have to be strong enough to actually wake up your brain from sleep.
And again, it's not uncommon. About 5 years old, about 15 to 20% of children are still having accidents at night.
Yeah, it's really, really common. I see this so often, and it's, and I almost always, when we really talk about genetics, it is really genetic. Like, I will say, hey, do you have anybody in the family who ever had a long time, like, with wetting the bed at night? And they're like, oh, yeah, my brother wet until he was 12.
And you're like, so that'll be your kid, right? If it's not happening in that first year after daytime training, you're probably going to have a genetic component that whatever age happens in your family, that's what's going to happen.
But the rate slowly decreases with age. It's still 5% at 10 years, and still 1 to 2% at even 15 years of age. So it is not an uncommon thing to have some wetting at night, and so important not to try very hard not to get frustrated by this and shame your child or make them feel bad about it. These are kids that often truly cannot wake themselves to go pee. So I actually tell parents that I'm more worried about them waking because they won't hear fire alarm,
right? They're just deep sleepers. Yeah.
They are so deep sleepers that not even a fire alarm will wake them. So if a fire alarm is not going to wake your child, do you really think their body is going
to? Their bladder is going to tell them? No. And, once your kid has it, it resolves spontaneously at a rate of about 15% of kids per year. It will improve. And the longer you have it, the less that it will spontaneously resolve and may need some help at some point.
And the big thing, we kind of separate this into the primary nocturnal enuresis is with the kids who've never been dry at night. And that's kind of what we were talking about here. Mm-hmm. These kids were never dry at night. You also have the diurnal enuresis, where that's what we were talking about earlier, when they have bladder and bowel problems. So they're probably not going to be dry at night, but they're also kind of not dry during the day. Right. And that's a whole different list of reasons than you're just primarily at night.
And then secondary enuresis means they were initially dry at night, but now they're having accidents again. And this is a lot more complicated, and you should definitely see your provider to discuss that, because the list is a lot longer and a lot more complicated.
Yeah, and can include other things that need to be treated right away, like urinary tract infections can be one of the reasons why all of a sudden you're waking, or that you're having to pee at night.
So treatment for primary nocturnal enuresis starts with treating any underlying condition. Again, constipation, super common. If you can't urinate frequently enough during the day, then you're going to pee at night. And so you have to make sure your child pees at least 4 to 7 times per day, including right before bed.
That's right. Waking them at night is just going to be frustrating for you and the child. Again, the kids who have primary enuresis are not going to be woken easily. They are really going to resist it. You are having to wake yourself up in the middle of the night, which is also truly not fun.
No.
So I instead just really recommend taking those precautions that make it less frustrating for everybody.
Yeah, so protect the bed with, a washable, absorbing water cover, right? And maybe even like a little chucks pad underneath there. It's okay for them to wear pull-ups that are designed for wetting at night. And they make like some big kid ones that don't look as diaperish, that are made to wick away the fluid away from the skin.
So that they don't get irritated or more moisture there than they need to. You can restrict fluid a little bit in the very late evening, like prior to going to bed. We don't really recommend like restricting a lot of fluid for children because, again, we want them to be drinking and peeing normally and getting all those
And not getting more constipated.
and peeing during the day.
Yes.
That's when they're supposed to be peeing, right? So you can try to get them to drink more in the morning and the afternoon, but if they're really not, don't restrict their drinking.
Yeah. Alarms have been shown to be very effective, but only when you're at that point where they're not wet every night. If they're still wet 7 days a week, it is not worth trying in them at that point.
It is really not worth trying alarms. However, once they actually start waking themselves up and you're like, oh, actually,
We're getting close.
Yeah, 2 to 3 nights a week, they're actually dry. That's where your enuresis alarms or your wetting alarms, bedwetting alarms can actually be helpful. I kind of like the vibratory alarms more than the...
Vibratory. I like that. Vibratory. Yes, because it's less scary to everyone in the house.
That's right.
Even though that kid will sleep through the fire alarm, not everyone else will sleep through the fire alarm.
That's right. You're going to wake up to that kid's alarm on their diaper, or on their, not diaper, but on their pull-up.
Yeah.
They won't.
Yes.
So, however, the vibration ones actually are pretty irritating.
Yes.
And so already if they're kind of starting to wake up for that, it is often enough to wake them.
And it will take a while once you're doing the alarms. I mean, it's going to be at least 3 months. Sometimes it's up to 6 months. So you have to have a highly motivated child who is ready to be done with it.
That's right. And this has the best chance, truthfully, of staying dry. So of all the things we look at to treat nocturnal enuresis, the enuresis alarms that you start once they've started being dry at night have the best chance of actually succeeding and not having a relapse after you stop them.
And then desmopressin, which is DDAVP, is a medicine that can be used, again, for these kids who are not wetting every night anymore, but it really only helps in the short term, like for camp or for spend the night at someone's house. And if you use it every night, it eventually will stop working. So it's good to have it as a backup for when you need to be dry.
And it will also, they'll relapse off of it. So it is not a cure of enuresis.
Just kind of a little Band-Aid, but it's a useful Band-Aid and a safe one to do.
It can be a useful Band-Aid. And then finally, the other thing we talk about in urine that we won't spend a lot of time talking about all the reasons, but it's important to recognize is that hematuria or blood in your urine is never normal,
right? So whether it's kind of brown like Coke, or always we used to say iced tea, right? Or just bright red, all of it is not right. Unless you're on your period, that needs medical attention pretty quick.
That's right. So that's when you just want to get in right away to get checked out if you ever see blood in the urine.
Okay.
And we hope that this information helps you keep your child's urinary system happy, healthy, and safe.
Yes. I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
This is a pod full of pediatrics.